Good morning, everyone. My name is Dr. Kondapalli Mautika. I'm today presenting topic of exotropic deviations stacking away numerous neuroophthalmological conditions. Introduction. Concomitant exotropias are common presentations in strabismus and neuroophthalmology OPD. As we all know, exotropias are outward deviation of the eye and they are most common strabismic complaints. But most common presentations with neuroophthalmology OPD patients present are restriction of extraocular movements and double vision. Some exotropias are actually the indicators of underlying neuroophthalmological conditions. Relevant history, examination, documentation of comorbidities, and neuroimaging are important tools to grab the diagnosis. My purpose of the study is to present 3 cases of exotropias in neuroophthalmological background. Materials and methods. My study design is prospective observational study done in Department of Strabismus and Neuroophthalmology OPD, Sarojini Devi Hospital, Hyderabad for a duration of 3 months. Coming to the study proper, out of all the patients presenting with chief complaints of outward deviation of the eyes, 3 cases were presented. Comprehensive orthoptic ophthalmology evaluation along with refraction, anterior segment examination and fundus examination were done. Neuroimaging wherever necessary was advised. Coming to the first case, a 48-year-old male patient came with the complaints of drooping of upper eyelid, prominence of left eye, dull pain of the left eye, headache, double vision in the left eye since 2 weeks. History of weight loss since 1 month is seen. He is a known alcoholic since 15 years, no history of other comorbidities. On examination, compensatory head posture is present in the form of face turn towards right. Facial symmetry is lost due to left brow elevation. Ocular symmetry is lost due to proptosis and ptosis. Vision in both eyes is 636 with pinhole improving to 624. Hertels showed axial proptosis in the left eye. HCRT showed 10 degrees exotropia in the left eye. Extraocular movements are grossly limited in all the directions in the left eye. Anterior segment examination, no abnormality is detected. This is a 9-gaze picture of the patient, which is showing the restricted movements in all gazes in the left eye. MRI of brain and orbits with contrast is showing T2 heterogeneous iso to hypointense lesion with intense heterogeneous post-contrast enhancement, the feature suggestive of orbital inflammatory pseudotumor. Management diagnosis of left eye orbital inflammatory pseudotumor was confirmed and patient was started on tablet Vizolone 60 mg once daily and drastic improvement within 1 week is seen. Second case, 52-year-old male patient came with the complaints of sudden loss of vision of right eye, drooping of upper eyelid, headache, double vision since 10 days. History of lead, painful vesicular lesions over the right side of the forehead and scalp is seen 20 days ago, for which he received no treatment. Vision in the right eye is 160, not improving further. HCRT is showing 20 degrees exotropia and extraocular movements are limited in all the directions except abduction in the right eye. Wirth-Fodor test is showing diplopia. Anterior segment examination is showing right eye of RAPD. These are the vesicular lesions present on the forehead of the patients, and this is a 9-gaze picture showing the exotropia in the primary gaze and limitation of movements in right eye. Diagnosis of right eye herpes zoster ophthalmoplegia was made, and the patient was started on tablet acecloprid 400 mg 5 times a day, and the patient was lost to follow-up. Third case, a 48-year-old male patient came with the complaints of double vision, outward deviation of the left eye, pain and headache since 20 days, which is acute in onset, history of transient ischemic attack 1 month before the symptoms was there, known case of hypertensive on medication. This is a 9-gaze picture of the patient presenting with exotropia in the primary gaze and adduction deficiency in the left eye. Compensatory head posture in the form of right face turn is seen. Facial symmetry is fairly maintained. Ocular symmetry is lost due to left eye exodeviation. In HCRT, 20 degrees exotropia is seen in the left eye. Extraocular movements showed adduction deficiency along with ataxic nystagmus on attempted dextroversion in the right eye. Investigations were done. MRI of brain with contrast showed tiny hyperintensities in the left corona radiata and pons with restriction on diffusion suggestive of acute infarcts. Diagnosis of left internuclear ophthalmoplegia was made. Appropriate counseling of the patient and neurophysician referral was made. In conclusion, the presence of an exotropia, particularly if it is incompetent, may represent a manifestation of neurological disease. Careful quantitation, observation of any associated neurological signs and symptoms, and consideration of the factors which contribute to adduction, convergence, or conjugate gaze may aid in differential diagnosis of these conditions. This study emphasizes the importance of complete and thorough examination of all the exotropia cases to look for other associations and take help of neuroimaging wherever required. Thank you, and special thanks to my guide and co-author, Dr. Raman sir.
For the second patient, what was the optic nerve findings? Vision was 1/60.
Vision was 1/60. There was no disc edema as such.
or disc pallor, nothing?
No disc pallor was nothing, ma'am. The involvement is purely retroorbital.
Patient appreciated diplopia with 1 meter vision.
Which patient, ma'am?
Second patient that you told RAPD is there.
Yes, ma'am. Yes, ma'am, he could.
Yeah, it's a little unusual with a 1/60 vision.
Yes, ma'am, but it's actually acute in onset, so he complained initially.
Yeah.
Thank you.